Welcome to section 7 of musculoskeletal anatomy. In this video, we'll discuss the hip. Let's get started. This is an image of the hip and surrounding bones. The hip joint is formed between the acetabulum and the femur and is important for movement of the lower extremities. Let's discuss some of the muscles surrounding this region and their associated actions in a bit more detail. We introduced this image in the last video, but it's a great way to review the hip. From the image, you can see the hip flexors, which includes the iliacus, iliopsoas, sartorius, and tensor fasciae latae muscles. Notice that the psoas major and the iliacus muscles merge below the inguinal ligament, you can see that right here, to become the iliopsoas muscle right here. The psoas major muscle is probably the highest yield muscle to be familiar with because when it merges with the iliacus muscle to become the iliopsoas, it's involved in hip flexion. However, above the inguinal ligament, it's associated with movement of the trunk. Notice that it runs from the vertebral column across the hip and inserts onto the femur bone as the iliopsoas muscle. This makes the psoas major and iliopsoas muscles unique because they can facilitate hip flexion, but can also facilitate back flexion. So if you're laying on the floor in the supine position and you attempt to sit up, the psoas major muscle will be used. Obviously, the trunk muscles like the rectus abdominis will be used, but remember that the psoas major muscle also facilitates this motion. On the posterior aspect of the leg, you can also see many of the hip extensors, including the gluteus maximus, semitendinosus, semimembranosus, and biceps femoris muscles. The hip adductors include the adductor magnus, as well as several others that can't be very easily seen in this image. On this image, you can better see these muscles, which includes the adductor brevis, adductor longus, gracilis, and pectineus muscles. The hip abductors include the gluteus medius and gluteus minimus muscles. There are also other muscles involved in internal and external rotation of the hip, but these are much less important to be familiar with. The way these muscles and their associated actions are most applicable is by understanding nerve lesions. So let's focus on this now. In the last video, we covered all of the nerves of the lumbosacral plexus in detail from this table, except the superior gluteal and inferior gluteal nerves. That's because these two nerves are probably easier understood in the context of this lecture. The superior gluteal nerve originates from the L4 to S1 region and provides motor information responsible for hip abduction and stabilization of the pelvis. The muscles innervated include the gluteus medius, gluteus minimus, and tensor fasciae latae muscles. The nerve can be injured due to an improperly placed intramuscular injection, which I'll show in a second. When the nerve is damaged, patients may exhibit the Trendelenburg sign and the gluteus medius lurch. This can be a little difficult to visualize, so I'll show you an image of this in a second to help you see how it works. First, let's look at the nerve and how it's injured. So you can see the superior gluteal nerve right here. Notice that it's located in the superomedial aspect of the gluteal region. Therefore, if an injection is improperly placed in this region, the superior gluteal nerve may be damaged. This is why an injection should be placed towards the lateral aspect of the gluteal region right here in order to avoid injury. Like we just discussed, if the nerve is injured, then the patient will exhibit the Trendelenburg sign and the gluteus medius lurch. This image provides a nice overview of the clinical presentation of someone with a superior gluteal nerve injury. On the left, you can see the Trendelenburg sign, and on the right, you can see the gluteus medius lurch. Let's talk about the Trendelenburg sign first. Notice that the patient's right superior gluteal nerve is injured. As a result, the right gluteus medius and gluteus minimus muscles are weakened. From the image, you can see that the contralateral hip drops as the patient stands on one foot. So the patient is standing on one foot and the hip drops like this. This makes sense, right? The patient's right side is weak. So when the right-sided muscles are isolated by having the patient stand on one foot, they fail to contract and the pelvis becomes unstable. The right side of the pelvis protrudes out laterally like this, and the left side of the pelvis dips downward, as I just showed. Okay, now let's discuss the gluteus medius lurch. This deals with the same principle, but is a finding that occurs when the patient walks. So notice that we've labeled it walking. As you can see, the patient leans towards the ipsilateral injury while walking to compensate for pelvic instability. So the patient's body is kind of tilted in this direction. So in summary, when the superior gluteal nerve is injured, you may see the Trendelenburg sign and/or the gluteus medius lurch. Okay, moving on to the inferior gluteal nerve. This nerve originates from the L5 to S2 region and provides motor information to the gluteus maximus, which is responsible for hip extension. This nerve is often damaged due to a posterior hip dislocation. From the overview image, notice that the inferior gluteal nerve, right here, can be seen emerging below the piriformis muscle as it wraps back up towards the gluteus maximus muscle. can see that muscle right here. Understanding that this nerve emerges below the piriformis muscle and wraps back up towards the gluteus maximus muscle is high yield for step 1. We discussed the obturator nerve in a lot more detail in the last video, so we're not going to cover it again, but keep in mind that this nerve is important for hip adduction. Okay, now that we've covered many of the important muscles and nerves of the hip, let's discuss a few other important pathological tie-ins. Trochanteric bursitis is inflammation and pain that occurs lateral to the greater trochanter of the femur. The gluteal tendon and bursa are involved, and the treatment is conservative, which includes heat, stretches, and NSAIDs. If we look back at this image of the hip, you can see that the greater trochanter is right here. Developmental dysplasia of the hip is a musculoskeletal abnormality seen in newborns where the development of the acetabulum is disrupted. So if we look back at this image of the hip, you can see that if the acetabulum doesn't develop properly, then the hip joint is affected. So this results in hip instability. There are 2 physical exam maneuvers that can be helpful in making this diagnosis. These include the Ortolani and Barlow maneuvers. Let's pull up an image so you can see what these look like. The Barlow test involves several steps. First, the knees are flexed to a 90-degree angle. Second, the thighs are brought towards the midline, which you can see is indicated by this arrow right here. And third, the examiner applies force posteriorly, which you can see by this arrow, which essentially attempts to push the head of the femur away from the hip joint. If the dislocation is palpable, then the test is considered positive. The Ortolani test can be helpful in confirming the Barlow test. And in this test, the hip joint is slightly abducted, as you can see by this arrow. Then the examiner pulls anteriorly on the thigh, which is indicated by this arrow, which essentially places the head of the femur back into the hip joint. If an audible click is heard, then the test is positive. Once the diagnosis is suspected, it can be confirmed with ultrasound. X-rays are not used because the cartilage in the hip doesn't develop until around 4 to 6 months. The treatment includes splints or harnesses. Slipped capital femoral epiphysis, or SCFE, is a condition that is often seen in obese adolescents. It occurs due to a fracture through the growth plate of the femur that results in a displaced epiphysis. Recall that the epiphysis is the end portion of the bone, which you can see right here. So this region of the bone is displaced. It usually presents with hip or knee pain and an altered gait. It can be diagnosed using an X-ray of the affected joint, and this condition is treated surgically. This is an X-ray of SCFE. You can see the growth plate right here, and the area above the growth plate, or the epiphysis, right here, has slipped. Legg-Calvé-Perthes disease is a poorly understood condition characterized by avascular necrosis of the head of the femur. We discussed avascular necrosis in the cardiovascular anatomy chapter, so we're not going to discuss it in detail now. However, very briefly, recall that this is caused by poor perfusion to the head of the femur, which results in an infarction of the bone. In Legg-Calvé-Perthes disease, the reason for the avascular necrosis is poorly understood. It's often seen in children between the ages of 5 and 7 and presents with hip pain and difficulty walking. Males are much more commonly affected with a male to female ratio of 4 to 1. Something that's kind of unique to the condition is that the initial X-ray is frequently normal. Okay, let's review with a question. A 59-year-old female presents to the office due to hip pain. She has a history of osteoarthritis, which has been refractory to non-steroidal anti-inflammatory drugs. The physician performs a deep intramuscular injection in an attempt to alleviate the pain. The patient returns to the clinic the next day due to difficulty walking. When asked to stand on the left leg, her right hip dips downward. Where was the injection most likely placed that resulted in this patient's condition? A, the inferomedial aspect of the left buttock. B, the inferomedial aspect of the right buttock. C, the superolateral aspect of the left buttock. D, the superolateral aspect of the right buttock. E, the superomedial aspect of the left buttock. Or F, the superomedial aspect of the right buttock. Okay, hopefully from the question stem, you notice that this patient has a positive Trendelenburg sign because when she was asked to stand on the left leg, her right hip dipped downward. Recall that this is caused by an injury to the superior gluteal nerve. This often occurs due to improper placement of a deep intramuscular injection in the buttock, which is what happened with this patient. So the correct answer is E, the superomedial aspect of the left buttock. If we look back at this image, we can see the superior gluteal nerve right here. Recall that it emerges above the piriformis muscle as it innervates the gluteus medius and gluteus minimus muscles. Also notice that the nerve fibers terminate in the superomedial quadrant of the buttock, so about right here. Therefore, if an injection is placed too medially and too far superiorly, the superior gluteal nerve can be damaged. This is why injections to the buttock should be placed laterally right here, in order to avoid nerve injury. From this image, you can see the Trendelenburg sign on the left. In this image, the patient's right superior gluteal nerve is injured. So as the patient stands on the right foot, his left hip drops. This is the opposite presentation of what was described in the vignette. Recall that in the vignette, the patient stood on her left foot and the right hip dipped downward. Therefore, we can conclude that the left superior gluteal nerve must have been injured due to an improperly placed injection. So again, the correct answer is E, the superomedial aspect of the left buttock. The inferomedial aspect of the left buttock can damage the sciatic nerve due to its large size, but this would not result in a positive Trendelenburg sign, so A and B are incorrect. The superolateral aspect of the left buttock is the ideal location for these types of injections, so C and D would likely have not resulted in a positive Trendelenburg sign. So C and D are incorrect. F is incorrect because the patient would have presented with a positive Trendelenburg sign on the opposite side. So again, the correct answer is E.